Welcome to podcast 15.
Hello, I'm Fran.
And I'm Minnie.
And as always, we'd really appreciate your feedback on this podcast. Thank you.
So today's podcast is on ectopic pregnancy, and we'd like to thank Ekende for suggesting this topic to us. And as we always do, we like to give you a tip. So today's tip is always do a pregnancy test in any woman of childbearing age who presents to you with abdominal or pelvic pain.
Perfect. I think that's really true, Minnie. So what is an ectopic? Well, an ectopic is a pregnancy that occurs anywhere outside the uterus. And most commonly, this is in the fallopian tubes.
Okay.
So in the UK, the rate is 1 per 100 pregnancies. So that's 1%. And it increases slightly in patients receiving IVF, which is increasing in the UK to about 4%. And although the mortality is decreasing, it's still 0.2% of ectopic pregnancies do result in maternal death.
So, Fran, I was trying to find some statistics into ectopic pregnancies in Africa, and actually it's really difficult to find anything up to date. But it's thought that the maternal death rate is much higher in Africa, 1 to 3%. And this is probably due to late presentation or late diagnosis of this condition.
Yeah, and it doesn't surprise me at all that the rates are higher, because we certainly know STIs and pelvic infections have a much higher incidence in Africa than they do in the UK, and as we'll talk about, they are a risk factor. So as I mentioned, most ectopics occur in the fallopian tube. So that's 97% of ectopic pregnancies. And the remaining 3% can occur in the cervix, in the fimbrials, ovarian and peritoneal sites, as well, interestingly, I did not know this, in previous caesarean section scars.
So are any of these pregnancies viable outside the uterus?
No. So there are these incredibly rare documented cases, but as a general rule, only a intrauterine pregnancy is viable. But what you can get is an ectopic pregnancy that coexists with an intrauterine pregnancy. So this is called a heterotopic pregnancy. So I didn't know this word before, but I have heard of this. And it's incredibly rare, occurring in 1 in 30,000 pregnancies. So I'm presuming as a GP, I will never see this in my lifetime. And mainly in IVF pregnancies where, so although this is decreasing in the UK, they always put back 2 embryos. So obviously you've got risk with that.
Yeah. Okay, so let's think about other risk factors then that increase your likelihood of having an ectopic pregnancy. You've already mentioned a history of pelvic infections, STIs. In fact, schistosomiasis is another one that can increase ectopic pregnancy. I remember reading when I was doing the blog for that.
Oh, that's interesting. Yeah. And is that because it damages the pelvis, or does it not say?
Well, it's just to do with it, affecting the pelvic region, and if you've got genitourinary schistosomiasis, it leaves scar tissue and damage.
Yeah. So the it's thought that anything that slows down the transportation of the ovum predisposes to an ectopic. So although actually 1/3 of women who present with ectopic pregnancies don't have risk factors, we know that there are things that increase the risk, like we talked about, pelvic infections.
So adhesions.
Adhesion. So again, this could be from infection, from endometriosis, from previous surgery. Maybe they've had a burst appendix, a burst ovarian cyst, IVF treatment we talked about, tubal surgery. Maybe they've had a hydrosalpinx, or they've had their sterilization reversed.
And history of a previous ectopic pregnancy also puts you in an increased risk.
Yeah, and also using a coil. So although you're very unlikely to get pregnant with a coil there, so it's something like 1 in 1,000 users would become pregnant. Of those pregnancy, approximately half will be ectopic. And so I had a patient. High alert. So I had a patient who presented who had a Marina coil in and felt the symptoms of pregnancy very sensibly. Luckily, she was a pharmacist, did a pregnancy test, realised the risk of it being an ectopic and presented early, and in fact it was an ectopic.
Gosh.
And obviously so she had surgery and isn't going to use a Mirena coil again for contraception.
I can imagine.
Yeah.
So
Slightly put off from that. Yeah.
So it's similarly with risk with women using progesterone contraceptives. Is that right, Fran?
Yeah, but actually it does say that if you've had an ectopic, it doesn't exclude you from using them in future. Okay. And Minnie and I were talking earlier saying that actually it's very hard to do studies on ectopics because humans are the only species who have them, that in other mammals that unfortunately we sometimes do experiments on, they don't get ectopics, so it's not something that we can study outside of humans.
Which is really interesting, and probably for another podcast discussion.
Yeah,
maybe.
Yeah. Right, so we've got a case.
Okay, so the case is we have a lady called Maria. She's 23 and she's presented to us with pelvic pain in early pregnancy. She knows she's 8 weeks pregnant from her last period. And she's presenting to you with pain in her right iliac fossa. It's constant, it's getting worse. She feels lightheaded and has fainted once. She's had no PV bleeding. This is her first pregnancy, and it's a planned pregnancy. And she's been otherwise fit and well with no history of STIs. And the only surgery she's ever had was for an appendicitis when she was 18. And she's on no medication.
Yeah, so how does it start? Well, an ectopic pregnancy starts with implantation, and the patient may just have normal feelings of pregnancy. But as it progresses and grows inside, the fallopian tube is distended, stretches and starts to bleed, and it reaches a critical size, and the tube ruptures at approximately 5 to 6 weeks after implantation. Mm-hmm. So as we said earlier, be aware that it can present atypically. So in any woman of reproductive age, consider the need for a pregnancy test. So in fact, I had a patient who presented with pelvic pain. She actually called an ambulance out in the night for it. And they didn't do a pregnancy test and presumed it was a reaction to a thrush pessary that she had inserted the previous night. And she somehow made it in to see me the next morning and was very unwell. She had rebound, she had guarding, she was lightheaded, rushed her off to hospital. And in fact, and this is such a classic thing that I've always been taught, subsequently she said, well, actually my last period was a little bit light and a little bit shorter than normal. And that's, so for me, that's always been this massive red alert. When I was doing gynecology, they always said, if they say they haven't missed a period, just ask what the last period was like, because if it was different, it may be that it wasn't a proper period and they were actually pregnant. So anyway, luckily this woman survived, but that for me was a massive thing that, just think pregnancy in these people.
Yeah. Well, and then a pregnancy test is easy to do, isn't it? So
well, that's it. And in fact, actually, I mean, where I work, there's a shop called Pound Stretcher opposite, where you can buy things for £1, which is very cheap in the UK, and you can buy a whole heap of pregnancy tests for that. So actually, most of my patients, if they have anything sort of pelvic related, they will all have done at least one pregnancy test before they come in to see me. Yeah, it's extraordinary. So it can resemble other common conditions such as urine infections, gastrointestinal things. But classically, how does it present, Minnie?
So the most common symptoms are abdominal pain, usually one-sided, or pelvic pain. As you mentioned, they may have missed a period or had a light period the month before. And if they've had any vaginal bleeding, it's usually very light and not really significant at all. Other symptoms that are common, but again, as we discussed earlier, Fran, these are often common symptoms of pregnancy, dizziness, feeling a bit faint, sort of urinary symptoms. You can also get diarrhea and vomiting with gastrointestinal symptoms, rectal pain. So lots of sort of symptoms that are sort of quite general, really.
Yeah, absolutely. And if the patient's well enough, then you should be asking about the risk factors for ectopic that we went through before.
Yeah, but clearly if they present you in hypovolemic shock, you're just going to get on and resuscitate and transfer to hospital as quickly as possible.
And beware that so Minnie said that you mentioned, didn't you, Minnie, that the bleeding will tend to be light. So most of the bleeding, if it ruptures, will be into the pelvis, not vaginally. Yeah, so it won't be visible and maybe misleading. Yeah.
Okay, so when you do an examination, Fran, what are you looking out for, and what are you avoiding?
So obviously with any examination, you're going to be approaching the patient first, and we've talked about them maybe being in hypovolemic shock. So you're going to be doing your ABCs of resuscitating them. But once you've checked that they're stable, the most helpful thing is going to be doing a pelvic examination, and you're going to be looking for pelvic tenderness, so right or left-sided typically, possibly with guarding, which is when the muscles tense up around that area, and with rebound. So that's when you the way I was taught to do it, I don't know if you do differently, Minnie, is that I percuss.
Yes, I was just going to say.
Is that what you do?
Percussing is the kindest way to elicit it. The kindest way.
So you percuss over the area where they're sore, and if they hit the ceiling, you know that something's going on in there. We don't do an internal. So that it's thought to be a possible increased risk of rupturing an ectopic pregnancy if you do palpation internally. So don't do it, please. Okay, particularly if you've got access to ultrasound. But if you think it's an ectopic, if they're pregnant, you need to be sending them to hospital. So other things more worryingly we'd be looking for is pallor. If they've got abdominal distension, that could be bleeding into their abdomen. If they're tachycardic, hypertensive, in shock or collapse. But those, if they're tachycardic and hypertensive and in shock, you're not going to be feeling the abdomen as your first line. As Minnie, as you so rightly said, you're going to be putting in a cannula and resuscitating them.
Yeah. With fluids in this instance.
Absolutely. Yeah.
Okay. So obviously we always like to think of the differential diagnosis as well with any presentation. So what other things might we be thinking about?
So the most obvious thing in early pregnancy is this a threatened miscarriage. And typically with that, the vaginal bleeding is much more dominant, and the pain is less, and tends, in my experience, it tends to be much more diffuse. So an ectopic tends to be much more one-sided, and in a miscarriage, it tends to be much more across all the lower abdomen with much more like a period pain, but worse. And then as other differentials are for any other sort of right or left-sided pelvic abdominal pain. So with Maria, hers is on the right-hand side. If she hadn't had her appendix out, you might be thinking, is this appendicitis? Could it be an ovarian cyst that's ruptured? Other things like that. Yeah.
Okay. So as we've said, we're going to do a pregnancy test on all these women that present to us with of childbearing age who present to us with abdominal pain. Even if it's highly unlikely that they're pregnant, you just want to be sure that you're not going to miss this diagnosis.
Absolutely.
So you were saying that down in Oxford you pop along to Poundland and get your pregnancy test. When they come to see you, what do you do, Fran?
Oh, so I do actually have some pregnancy tests in my drawer, but I do have some, but I only use them if I'm thinking it's an ectopic pregnancy. Okay. Yeah. So, but then I would be, so if I'm worried about an ectopic, I'd be admitting them to hospital, even if they're stable, same day, and they would be scanning them. And that's it. So from 6 weeks from their last menstrual period, so that's 4 weeks after implantation, is when they can actually see something on a scan. Before that, you can't reliably identify anything on a scan, pregnancy-wise. So they're looking for the location of the pregnancy, whether there's a fetal pole and a heartbeat. And they would also be doing a blood test for HCG. So this is human chorionic gonadotrophin, which is the pregnancy level. And what you're looking at is to see what the level is your baseline, and whether it's increasing or decreasing. Okay,
so you were talking earlier to me about when they can't find the pregnancy.
So sometimes they do the blood test and the woman obviously is pregnant, but they can't actually find the pregnancy on scan. So it's known as a pregnancy of unknown location, and a PUL, which is slightly confusing. actually half of these just resolve on their own. So what they do is they just monitor them. They monitor the blood test to see whether the HCG level is coming down, and they rescan to see if anything has changed in the pelvis.
Okay.
But about half of them will self-resolve. But
so the management of an ectopic pregnancy, I suppose we ought to go through that in quite clearly, really, hadn't we?
Yeah. So sorry, I'm so sorry. I said about half would resolve, but actually apparently 2/3 would resolve spontaneously. My apologies.
Right. Okay.
So with Maria, when we examined Maria, she was pale. She was tachycardic at 110 beats per minute. Her blood pressure was 70/50. Her abdomen was very tender with guarding rebound in the right iliac fossa. So we have called her an emergency ambulance. We have put in the cannula and we've put up some fluids. And when she gets to hospital, they are going to be operating on her because she has ruptured her ectopic. This is a life or death situation. So they're going to be doing a laparoscopy and either, so sorry because I'm leaping about Minnie, they're either to be removing that tube, which is called a salpingectomy. And in the UK, what we do is we look at the other tube, and if the other tube looks fine, then they would remove the damaged tube and the ectopic. If possible, and the other tube looked damaged or she had other risk factors for infertility, they do a salpingotomy where they open the tube up, get rid of the ectopic, stop the bleeding, and then the tube heals by secondary intention, and that just preserves the tube, giving her an increased chance of future pregnancies. So that's what we'd be doing for someone who is very unwell.
So in those that are stable, what are the options?
So much more now we're doing medical management in the UK, which is brilliant. And this is a change from when I worked in gynecology, which is now 20 years ago. But actually we now use methotrexate, which historically we've pretty much only used for rheumatoid arthritis. But they've done a lot of research, and they found that a single dose treatment with methotrexate has a similar efficacy to surgical. And obviously you're not having surgery with the risks of bleeding, infection, damage to your bladder, bowel, whatever, and adhesions later on. And it works as well, and also it's more tube sparing, so you're not going to damage the tube with surgery. So that's really good. So they have some criteria. So if the pain is not significant, if when they scan you the mass is less than 35 millimeters, there's no heartbeat, no intrauterine pregnancy, and your HCG is less than 1500, they will give you a one-off dose. The patient is likely to complain of some abdominal pain, possibly some nausea and vomiting, possibly some impaired liver function, which is reversible. And then they would be monitored, so they would have, again, repeat scans, repeat HCG levels to see what's going on. But it works incredibly well. The women, it's great. It's so much easier than all the surgery taking place. So much safer for everyone. You do need to use contraception for 3 to 6 months afterwards because methotrexate is teratogenic. And you do need, so this maybe won't come into play in rural Zambia because you need to be able to go back and have blood tests and things. So it does rely on people having access. Easy access to the hospital. And
I guess easy access during the treatment in case things don't go according to plan. So you'd need to be able to get back in if it became an emergency.
Exactly. And they're all given advice on, when to reattend if there are any problems. Yeah. So they're two quite different things. Just to note that if you are rhesus negative, if you have this medical management, you don't need anti-D given, but if you have surgery, then you do need anti-D.
Yeah. Okay. So the surgical management, which you've already mentioned briefly, obviously in an emergency when it's clear that somebody is ruptured and hypovolemic, but also you'd offer surgery to patients who aren't suitable for methotrexate. So if you mentioned the size of the adnexal mass, so obviously if it's too big or if there's a fetal heartbeat or there's significant pain or much higher levels of HCG, so over 5,000, then you're going to want to go down the surgical route. And obviously this is up to the obs and gynae to make those decisions.
Yeah, but I think it's just nice to know that this is what's going on in the hospital. So,
absolutely.
So, I find it really helpful knowing what patients might be being offered or being, so if they've had methotrexate, knowing what side effects they might be getting, all of this is useful information, even if you're not necessarily doing the treatment yourself. Yeah. So, as we talked, in the UK, we're diagnosing these earlier and earlier. So it's much less likely to be life-threatening than it has been in the past. But, if you miss it, if the patient doesn't present, then it can, as in Maria's case, lead to tubal rupture, and that can lead to massive hemorrhage, shock, DIC, and even death. So, this is something that women die from, particularly in the developing world, unfortunately. Yeah.
Okay.
Yeah.
And what's your risk after having an ectopic pregnancy of having another one, Fran? Does it put you at an increased, well, we've already said it's a risk factor if you've had one before.
Yeah, but actually less than I thought, Minnie. So it's one of these things, isn't it, that I think I've just seen a patient who's had a previous one and she now has another one. So she presented very early on at about 4 weeks from her previous pregnancy saying, I don't feel right. I feel like I might have another ectopic. And I said, well, you might, but I can't scan you. There's nothing I can do until you're 6 weeks pregnant. And unfortunately she does have, and they've been doing the medical management with her and just watching her. But actually, when I did some research, the risk of another ectopic pregnancy is only 10 to 20%.
So she's been pretty unlucky, really.
She's been really unlucky. Yeah. So much lower than I thought. And they say the chance of a subsequent intrauterine pregnancy. So note, this isn't the chance of a live birth. This is just an intrauterine pregnancy. Is 64 to 76%, which is pretty high.
Good.
Yeah.
Fantastic.
So going back to our case.
Yeah. So Maria has had emergency surgery, as we said, with a salpingectomy. She's required a blood transfusion because she'd obviously ruptured and had lost a lot of blood, but goes on to make a great recovery and then a successful pregnancy in the future.
Fantastic. Well, that's great news.
Yeah. Well, thank you for listening.
Thank you very much. I hope it's been helpful.
And we'll see you for the next podcast.
Thank you and goodbye.
Bye.